Good afternoon. I'm Deacon Dr. Cecilia Travick Jackson, and on behalf of the Mount Cross Church and the care team, I would like to welcome you to our second in a series of end-of-life issues. This particular presentation is on hospice and palliative care. We have two distinguished and knowledgeable presenters, Terry Hilton, RN, who holds a master's degree in nursing and has in-depth experience in palliative and hospice care. We also have Jennifer Christensen, a licensed clinical social worker who also has in-depth experience, especially in palliative care. When you entered, you received a packet, something like this. They will be going through this during the presentation. You also received a bookmark for all of your reading, and you received or you have access to index cards. These index cards will be very important as we go through the presentation and you write down any questions that you might have. So remember to write your questions down on the cards, and there will be time for your questions to be answered towards the end of the presentation. And you received a pencil. I almost forgot this. So there's no excuse for you not to write your questions down. At the end of the presentation, please go out on the patio for light refreshments, conversation, and just general mingling with old or new friends. If you find that you must leave early, we have refreshments to go, so you can grab and go. And you know that they are great refreshments because we have the chair of our refreshment committee, even though she doesn't think that she is, and Susan Prosser and Yvonne Cocheras. So they've taken great time in making sure that you have very good, light, and nourishing refreshments. So please take time to have some refreshments. Before we begin the presentation, I will ask if you will bow your head so we can have a short prayer. Dear God, thank you for bringing us together on this afternoon to discuss extended care for those we love and care so deeply for. No matter for your reason for attending, be you a caregiver, seeking information, or planning for your future care, may you find words of encouragement, knowledge, and comfort. Dear God, support and strengthen all those who reach out in love, concern, and prayer for the sick and the distressed. In their acts of compassion, may they know that they are your instruments. This prayer and all blessings are asked in the name of Jesus, the light and life of the world. Amen. And now I turn it over to Jennifer and to Terry. But give me a minute to move the microphone.
Did you walk the podium?
I don't need the podium.
Okay.
Yeah, that's good, thank you.
I can move this if it's still
That's fine, thank you.
Are you good?
Yeah. So you want me to open it up?
Yeah.
Okay.
Actually, you want me to open it up?
I can, well, were you gonna, I just go into it? Okay, no, I can open it up. So my name is Jennifer Christensen. I'm a licensed clinical social worker, and recently I also got my advanced hospice and palliative care certificate for social workers. So in addition to be a clinician and a therapist, now my other specialty is palliative care and a little bit of hospice, but right now I'm heavily involved in palliative care. I work at Community Memorial Health in Ventura, and we have both an inpatient palliative care program and an outpatient palliative care program, which is really quite unique in the county. But what I want you to know is that every hospital in this county has some sort of palliative care. I cannot vouch for what Pleasant Valley has, but they're part of Dignity Health, and there is a palliative care team at St. John's and Oxnard. In fact, I've met all these folks. Until recently, I worked at Adventist Health Simi Valley, and they started that palliative care team. And before COVID, we would do countywide meetings and share, because palliative care is a very new field. So if you haven't heard of it, don't feel badly. Most of the time when I reach out to patients or family members, they have not heard about palliative care. And the initial reaction is usually one of fear and confusion, because people associate it with hospice, but it's really its own thing. And it's different, it's similar, but yet different. And so just really one of my missions is to get the knowledge out there about palliative care, because it's such a new field, and I think it has so much to offer and so much to benefit.
Yes, it does. So I am Terry Helton. We've met before. I'm a registered nurse. I happen to attend, I call it our sister congregation, St. Columba's Episcopal Church. And I have worked at Pleasant Valley. I work part-time now for Livingston Memorial Visiting Nurse Association. I was a hospice nurse. So I've done hands-on hospice nursing. I have cared for people who are dying in nursing homes when I was an LVN, and I cared for people in the hospital when they were dying before we didn't even talk about GIP, did we? So I have a good idea of that, but I've worked with palliative care in the home health environment. So there's a little bit of differences. So as we approach into this, I wanted to put some objectives out here that we hope that you will have at the end of this. So to describe how hospice and palliative care support a person and their loved ones during the process. Describe the similarities and differences between hospice and palliative care, and then to identify when a person might be ready for palliative care or hospice. So I'm going to start because we put hospice first. So hospice definition, and I could do this from my heart, but I don't want to miss anything, so I'm going to read a little bit and then I'm going to talk. So hospice care is a specialized form of medical and supportive care with a focus on symptom management through a team approach. And what I like to say about that is she's going to talk about palliative care, and it's definitely symptom management. So hospice is always palliative care. Palliative care is not always hospice. So that'll make more sense as we talk. It is designed to meet the needs of the whole person. And this is really important to understand about hospice. It really is about the whole person. It's not just about their body and their symptoms and dying. It is about their psychosocial, their cognitive, and their spiritual parts. And I would say in this congregation, it's also about their sexual being. Sometimes we ignore that, but people have sexual needs too. It's recognized, hospice is recognizing dying as a normal and natural event. All of us, 100% in this room, were born. 100% of us are going to die. It is something that God has designed in His environment, in His world. If we look around, even as we plant, we see plants die, they bloom, they grow, they die. Nature happens this way. And I promise you, and if we looked at other literature outside of Christian domain, I promise you, without having a focus, even unconsciously, that we have an end, we would have no purpose in life. So God has helped us to say, we have a time limit, what is it I want to do? So it is a natural, normal part of life. Hospice neither hastens, and this is a misunderstanding that we're going to talk a little bit about, it neither hastens nor prolongs death. Hospice is there to support the family, the person who's dying. Hospice care can be provided in any setting which the patient lives in. So this can be a private home, it can be a board and care, which we call a six-pack, where people live, older people live in a board and care with other older people and get private care. It could be an assisted living like Almavia or Atria. It can be in a nursing home. And there are different rules that go for the nursing home, and I hope to remember to talk about that at the end. Hospice Benefits, I wanted to add in here. It is a nursing visit, and it varies from the beginning of hospice, what the person is like, to the end of hospice. So I had a person, one of my last people I cared for as a hospice nurse, who lived in the Reserve. What a horrible name. I still think it's a horrible name. The Reserve in Thousand Oaks. She lived in a 2-bedroom independent apartment. She had needed a valve replacement and decided that that is not something she wanted to do in her life and decided to go on hospice. This person drove, she made decisions for herself. She just knew that time was coming that she was going to face end-of-life decisions. So when I first met her, I saw her. It was almost a social event. It took the time to enroll her in hospice. And I didn't need to see her about every 2 weeks. And I would go and talk to her, and as time went by, in a few months, she needed a visit once a week, and then a visit every couple of times a week. And then we began to talk about, did she need somebody to help her around the home? So you see what I'm talking about. It was a slow process. There was a nurse available. I was the case manager. And at the end, she needed somebody every day. So it varies that way. A home health aide is part of the benefit. A medical social worker would be sort of like Jennifer. We have social workers and chaplains. The nurse is on call 24 hours, but the nurse does not stay there 24 hours. That has to be provided by the family, a 24-hour caregiver. But a nurse will be available 24 hours. And if you called a hospice agency, they would say, what is your need? They talk to you and they try to walk you through it if it's a medicine need, if it's a physical need. But say Jennifer had a need with her family member, and Jennifer said, I really need somebody to come. I'm really uncomfortable. They would say, we will send a nurse. And they would send a nurse out immediately. So if you have a hospice agency that's settled in Ventura County. So medical equipment. So if Jennifer's family needed medical equipment for that person, and the person I cared for didn't need anything at first, but as time went by, she needed a hospital bed, she needed an overbed table, she needed oxygen, she needed a bedside commode. All of that is covered by hospice. And the other part of that is she could have had a wheelchair and a walker. Now, people who have home health and they need a walker or a wheelchair, Medicare won't cover both. In hospice, they cover both. And different types of wheelchairs. Medications that are associated with the diagnosis are covered, and for pain control, sleep, that type of thing, and supplies. So if Jennifer's family member happened to be having skin tears or injuries, those supplies are covered. There's no extra charge. If a person can't void on their own and they needed a medical way of catheter being put in, that's covered. So the different supplies are covered, also depending on diagnosis.
And incontinence supplies. I mean, it's actually
Incontinence
my
supplies.
mom was on hospice, so this could be a real example.
Oh, it's a real,
Like
it's
it gives specifics.
It's very specific. So, and I'm going to say this, those supplies can vary a little bit by hospice agency. So some hospice agencies will be very glad to give you the wipes because they are a for-profit agency, where in Livingston, they're not going to be as willing to give you those wipes because they're a nonprofit. And they spend money to do other things, and they actually give subsidized care to people who are younger, who don't have Medicare, and we'll talk about costs later, who don't have Medicare, and they help pay for those coverages. So it's a lot, but it's also a wonderful thing, hospice.
Here we are. Okay, so with palliative care, really how I like to explain it, it's an extra layer of support for patients and families with a serious illness. Because there isn't enough knowledge about palliative care yet, I think a lot of people are going too long or they never get it. In fact, I think upon diagnosis of cancer or COPD or congestive heart failure, something like that, that's going to be really life impacting. Palliative care is appropriate, but as we're still just getting it started, everyone does not get it. I'm just going to start with the different levels so you can, because Terry was talking about home hospice. So, and LVNA does do home palliative care too, I believe. So there's a few, but home health agencies, some but not all, will do home health palliative care. And then there's some good agencies that do hospice where they can start with palliative care. So if you or your loved one is involved with one of those home health or hospice agencies, they can start palliative care. It runs more like home health. It's still not completely developed as much as I would like, but so you can get the visiting nurse, and as opposed to, which my daughter pointed out, because she volunteers with hospice and palliative care up at college, with palliative care, you can still get physical therapy, and you could still be pursuing cancer treatments and curative interventions, whereas with hospice care, it's a little bit more for end of life and comfort. But the nice thing about palliative is you can have that nurse coming out. You can have the doctor oversight. You can have physical therapy. You can have a social worker chaplain. You can have that at home for an extra layer of support to manage symptoms. I mean, our goal is to keep the person in their home longer. With palliative care, you can go to the hospital. With hospice, we're hoping not so much. So it's sort of in between, but I think it's still an underutilized service, and largely because out at home, we're still developing it more. So then the level that I'm most familiar with, because of my work, is at the hospital level. So picture this, you or your loved one is in the hospital, maybe they're in the intensive care unit, it's confusing, maybe there's a new diagnosis, you're not sure, maybe you're hearing they have cancer, or maybe their respiratory status is really going down, there's some sort of medical crisis, and you are contacted by someone on the palliative care team, or the physician says, well, I'd like to refer you to the palliative care team. First of all, if any of you are offered the chance to meet with palliative care, I hope you do take it and try to set the fear and confusion aside, because palliative care is not for end of life. Some of our patients do go on to be on hospice, but we're there. I mean, it's a covered benefit in the hospital, so you get a lot of bang for your buck. So someone will contact you. Oftentimes it's me as the social worker. Sometimes it might be the nurse, because we actually have 2 teams at CMH because we're larger. So we have 2 social workers, 2 nurses, 2 physicians, and then we hired a nurse practitioner as well. And then we have 4 chaplains that we kind of borrow back and forth. So you would get contacted by one of us, and we'll just reach out and explain and offer you a chance to meet with the palliative care team. So with COVID, it's kind of messed things up. We used to do all our meetings in person, maybe in the patient room or in the waiting room, but now sometimes people can't come in, so we can do phone meetings. But we really want to meet you where you are and just provide this extra support. And so what we call goals of care conversations, that I don't know how much that happens on home health palliative, but in the hospital, that is the main crux of our service, is what we call goals of care, because it's confusing and overwhelming. You might not be getting complete medical updates about yourself or your loved one, because that's just common. Doctors whiz in and out. They come in odd hours, and you might be left feeling confused. And doctors might be asking you to make choices. Do you want to go on a breathing machine? Do you want CPR? How do you feel about artificial nutrition? Do you want to continue these cancer treatments, or say you're having whatever aggressive care, but you're just having horrible pain, nausea, things like that. So we would schedule a meeting with the patient if they're able, and the family, and then just go through that whole thing. Make sure you understand what's going on medically, answer your questions and concerns, and provide a lot of emotional and spiritual support while helping support the patient and family through deciding how aggressive you want your medical care to be. Because people don't know what the options, there's a lot of misunderstandings and lack of knowledge. And of course, how would you know this? So we walk you through that process, and then symptom management, like in hospice, because our physicians are experts in pain control, nausea, vomiting, constipation, all those things. So that's inpatient. And then we're going to want to link you to something at discharge. So at Community Memorial, though we're kind of backed up and they're trying to expand the outpatient, we still do refer quite a few people to our outpatient service. Then you can go into the office or do telemedicine, and then they have a doctor and a social worker and a medical assistant and chaplain available. So they do meetings similar to us, but they can go on for months or years in some cases, as long as the patient still meets criteria. Most insurances cover that. Some of them need pre-authorization. But say that's not an option for you. Maybe you live in Camry, you don't want to go there, you live in Simi Valley, then we would probably look into palliative care through home health, because usually once people get to understand what palliative care does and they're not so stressed, they really appreciate it. And they say, well, can we keep seeing you when we leave the hospital? Can you come to our house? That's a really common question. And so our team can't, but then we'll try to match you up with a team that does. And in some cases, really, hospice is what the plan's going to be. And then we're referring you to some like...
To somebody like Livingston or Buena Vista.
Exactly.
So a little bit about home health, palliative care. Palliative care and home health is, as she said, based more on home health. And there's some rules with home health in order, and we're going to look at the bigger umbrella. It's Medicare paying for it. So usually when we're looking at home health and insurances, but mostly Medicare. And in that, they have rules. God bless them, they have rules. And so for everything in home health, if you had palliative care, you would have to have the order for a nurse and why that nurse has to have a visit. It has to be specific. You would have to have an order for the physical therapist. You would have to have a separate order for the social worker. You would have to have an order for the dietitian. So the doctor has to define, or the nurse practitioner, what that's about. So palliative care can be done in the home, and it is often done, and it's done well. The one thing you don't need an order for is the chaplain. So spiritual support can always be given, and in palliative care, that's what we're hoping we do, and that we have good social workers and chaplains who can help with that. So we look at that perspective. So unfortunately, in home health, it is a time limit on how long they can receive palliative care, and it sounds like outpatient is the same thing.
It's way more flexible.
It's way more flexible, but the looking at that is some limitations, and however, understanding that's important. Part of the language that I didn't think about until we were standing here is some of the language that's being changed is to have serious illness conversations. And the reason that is happening is that we're hoping individuals can go back to their primary caregiver, their physician or their nurse practitioner or PA, and if you have a serious illness, you can be the one to begin because they're not going to do it all the time. They may not think you're ready for this conversation.
They may not be ready for the conversation.
They may not be ready for the conversation. So unfortunately or fortunately, it's up to us to bring up the serious illness and begin to ask the questions and make them begin to take you in that direction. Because palliative care should start when that diagnosis happens, right?
I would like it to.
Yeah.
Isn't always good.
So if you have chronic lung disease, if you have cardiac disease, if you've been diagnosed with a chronic disease like cancer, dementia, Alzheimer's, kidney disease, all of those can benefit from palliative care planning, serious illness conversation, right?
Right. Well, I mean, it's lovely when we get in early. When I was at Simi Valley Hospital, it's a small hospital, and I was also the oncology social worker, so I had a little bit more luxury there, identifying the new cancer diagnosis and kind of funneling it. Now I don't get that opportunity, but I'm still hoping with growth we can reach more people, because optimally, palliative care is involved at the beginning. And I forgot to mention my piece, social work. I mean, it's emotional support and resources like insurance coverage, just whatever you might need. People need things, financial distress. They want more intensive psychotherapy. We help with that. I mean, ideally getting in at the beginning so that we can be there the whole time. And because one thing that happens still, and even happened in my own mom's case, even though I know all this, she was only on hospice about 2 weeks, and people get on hospice too late. So my hope is that if people are connected with palliative care through the months, years, or whatnot, they would be able to, and unfortunately, as Terry's saying, sometimes have to advocate for themselves with physicians and say, hey, I would like this. Could I have hospice now? You know, because the doctor, the average length of stay on hospice is just a couple weeks. It could be 6 months, or some people get recertified. So the reason palliative care is good early is so people are aware and empowered to ask for these services that are covered by insurance but may not get brought up.
So that's what I'm going to bring up here, is the hospice differences. Patient must have a terminal diagnosis and an end-of-life diagnosis so that your nurse practitioner physician can write an order saying this person has this diagnosis and write an order for hospice, and you can interview hospice agencies. And they all have to abide by the Medicare law. That's basically what they do. And that law says some of the things I told you already. But there has to be a terminal diagnosis, and that person we're kind of expecting to die within 6 months. But they don't have to die within 6 months. So a patient cannot be seeking curative or life-sustaining treatments, such as chemotherapy for cancer, heart valve replacement, dialysis. So a person who has end-stage kidney disease and they've been on dialysis and they're just worn out from this and they really just want to go on hospice, they're basically giving up their dialysis, and we know that there's a very limited time for their end of life at that point. So palliative care, they could be on dialysis,
Yes.
right?
Definitely.
So it requires a physician order, and that physician order is not separate for the social worker. It's not separate for all of those entities. It's one order for this whole umbrella of care. There's no endpoint to the care as long as the patient's declining, with continued certification for hospice based on patient decline. Now, remember, I was a hospice nurse. I know how to do this. And you do it honestly. We're not cheating Medicare. Actually, it saves Medicare a lot of money when we do this correctly. I had a patient in Camarillo that had been moved from her home from her son to a board and care. And that board and care gave such good care that when she went there, they thought she was going to die. I took her over as a hospice patient, and they gave such good care that she began to eat. She began to get herself out of sitting up in bed. They got her up to a wheelchair, and before you know it, she was walking. Guess what I had to do? I had to discharge her. I had to make sure that she had a doctor, that she was being cared for, that we were discharging her off a hospice, because our medical director was her doctor. It doesn't have to be that way, but it happened to be this case. So I had to make sure she had a doctor and all the medications, everything lined up. Lo and behold, about 6 months later, this lady had a stroke. And she went to Pleasant Valley. They sent her home. They thought she was going to die. Well, for over a year, this board and care took such good care of her and fed her and cared for her that she didn't die for a year. How did I keep her on hospice for a year? Am I cheating Medicare? I am not. Because she ate, and I knew that she would eat a big plate of food. And then as time went by, she was eating less food. And I would say in my notes that this is what's happening. She was interacting less. She was beginning to have, she never broke down in her skin, but she was beginning to have red spots, and she was getting stiffer. So all of those things I documented as decline, and she stayed on hospice for a year. So this is an honest way to do this. And actually, I know of somebody whose friend has been on hospice that long, and I know that that's what they're doing. And I promise I've never looked at the notes. I just happen to know that she's been on that long. So the other thing I want to say is in home health and palliative care, if they come on a home health and palliative care, they have to be homebound, meaning you don't go to the show. You really are not supposed to go out to dinner. The only place you can go to is church service once a week and to your doctor's office, medical appointments. That's homebound. In hospice, you do not have to be homebound. They want you to have quality of life. You could, well, in non-COVID times, you could go to the show, you could go out to eat, you can do all of those things, go shopping. It's not a problem if you are up to it. In fact, if you are in the contiguous United States, not counting Alaska and Hawaii, you can travel. I had a patient who had liver cancer, and he was younger, and he didn't want to go all through the cancer treatment. He just said, I'm done because I know what's happening. And he and his wife wanted to have an anniversary trip and celebrate his birthday. So they wanted to go to Washington State, and we set up a contract with a hospice in Seattle area where they were going, and said, if you come into troubles and you need anything, contact that hospice. That contract will be turned on, and you will be cared for there. So they take their trip. Lo and behold, they had to turn on that contract because our pharmacy blew it in providing him the medications he needed. So that pharmacy in Washington supplied the medications he needed, no cost to him, no issues. He came home from his travels. He had a vacation on hospice while he was on hospice. We didn't pay for it. He had a vacation while he was on hospice. So that is something people don't often understand, that hospice is there to meet the quality of life. And as she said, as Jennifer said, it's better to have it longer because you have emotional, psychosocial support for the patient, for the family. Positive things happen that feel really hard at the time, but sometimes people often get that opportunity to have family, personal healing happen.
And we know that people often live longer with hospice care as opposed to without hospice care. I mean, that sounds sort of paradoxical, but also with palliative care, because our goal is raising the quality of life with all the supports we can bring to it. So actually people may do better, because a lot of people feel like they're throwing in the towel or giving up. If I go on hospice, that means I'm giving up. We can't give up on this. I'm a fighter, can't give up. But I mean, the research does not bear that up. With hospice care, people may live longer. They're more comfortable and they're getting all the support. The other important thing to know about when you're on hospice, the goal is to not go to the hospital, but I want everyone to know that you can revoke hospice and go to the hospital. We don't want that to happen because that's stressful, but there could be rare occasions where even the hospice nurse recommends that, hey, we revoke it temporarily if the patient is just so miserable we can't manage the symptoms at home.
So, if you can't manage the symptoms at home, they don't revoke hospice. They can go into a general inpatient at the hospital where they can get continuous care, or you can get continuous care at home where there's medications brought in that they're a little more extreme. So it can work both ways. Also, people who care, and this is a little more difficult, there is Respite offered by Hospice Medicare for 5 days in a nursing home for, say, Jennifer was the only caregiver for her mother at that time, and she's worn out, or her daughter's graduating school in another state, that they can arrange for respite care in a nursing home for 5 days, and that's part of that coverage. I did want to give an example of another person who came off hospice, and it was temporary. I had a gentleman who had heart-lung issues, and I went in to talk about palliative care versus hospice, and they decided for hospice, and I'm calling, and we're going through the medication. And I'm going through this, and I'm hearing his lungs. I didn't even need a stethoscope to hear his lungs. And I'm going through the medications, and I'm calling the medical director, and I'm saying, so these are his medications, and the doctor's saying, so does he have any Lasix? It's a diuretic. And I said, no. And he said, well, let's stop this. Let's give him Lasix. Now, I need you to hear, we didn't make all of his medications go away like a lot of people think. Often people think when a hospice comes in, you do away with all these medications and you bring in all the drugs to kill them. That's absolutely not what happens. Especially if you're with an appropriate hospice. So if that's happening, you're with the wrong hospice. So we go in, and I read all the medications, and I'm going, this is what's going on, this is what he sounds like, this is what's happening. And the doctor said, okay, stop this, start this. And that cleared up his lungs for a long time. In fact, I had to discharge him. I have this habit. No, I only did it 2 or 3 times. So I discharged him, and then I went away on a trip, and I came back, and I heard that he came back on hospice because he also had a defibrillator in his chest at that time when I brought him on, and he did not want to have it turned off. And when he came back to hospice, and I was in India, he had decided and talked with his cardiologist that everything was done that could be done. He had enough. He had finished his plans with his family, and he decided to turn the defibrillator off. And he died within a week of coming on hospice again. So those are stories. Those are true stories. So.
Do you have that graphic? There's a graphic on there. Maybe not. We
Yeah.
probably went through all that. I like that one graphic. That one on the right. Maybe it's the next. That graphic. This graphic is something we use in education.
Point at it? Would you want to go over and talk about it?
Yeah. I mean, I think this makes it easier to understand, because it can be really hard, especially when you're emotional, to understand. So this is the continuum from health to death, and that's the trajectory of the illness. So you can see here, prevention, of course we want to do that, curative and life-prolonging care, symptom management. So see, this is under the palliative umbrella, where you're doing the curative treatments and the symptom management and all the emotional support. So see, palliative care can do we do some of the goals of care and talking about advanced care planning, but then when someone reaches the end of life, now it's going to go into hospice. So see, this is even, hospice does bereavement support for up to a year after the patient's death for the family. So just to notice that as it goes. That's why I wish people would get on very early, because you could be getting services this whole time. But I feel like very often people just come on here, end of life and dying, and maybe they don't think about this piece. So just to show how they fit together to, cover everything from the time of diagnosis. And feel free to ask for palliative care if you're not being offered it, because you might have to.
Yeah. So what was this? Oh, I thought I don't think I have the most updated one here. So how are costs of care covered? Yeah, I bet you're all interested in this part, right? So hospice, it's usually Medicare. And I already told you the rules for Medicare, basically. You have to have an order, you have to have a terminal diagnosis, and you have to show continued decline. And then Medi-Cal also covers, and we call this Medicaid in other states. And then most private health insurers follow the same guidelines as Medicare. Now, I happen to have an HMO, I have Kaiser. I am 65 years old, and if I had a terminal diagnosis, end-of-life diagnosis, and I decided for hospice, then what would need to happen is I would say I'm going on hospice, and what happens with Kaiser or any HMO, included United Health, HealthNet, other ones, is that it reverts back to Medicare, and Medicare covers it, so they follow the rules of Medicare. Now, if you're a federal employee, it's going to stay that insurance that you chose at the time they forced you to choose an insurance. And that, say it's Kaiser, then Kaiser's going to cover it like an insurance, and they still are supposed to follow the Medicare rules. And then most private, as I said, most private insurers cover it just the same way. And palliative care is it's gifts. It's often gifts. It's fee for service. If it's in home health, there may be a copay. I like to tell you that up front. And then this is the old one because I took off the few. There are private insurance who pay for it. And that's changing. Kaiser at one time fully covered palliative care, and then they withdrew that, and now other health insurers are covering palliative care, and Kaiser's considering doing it again for home health. And I have to tell you, it was one of the best events I ever had. It sounds terrible talking about this way, but I had a patient who had cardiac disease, and he wasn't supporting his feet, and he was getting wounds, but he wasn't ready for hospice. And so Kaiser paid for palliative care, and I would go out to his home and teach him about putting his feet up and doing certain things to get that circulation going. I was doing the palliative care treatments about this is what you're going to do, and this is what's going to help you stay out of the hospital. And he stayed out of the hospital for a year, went back in the hospital, and lo and behold, he was ready for hospice. Came home and went on hospice. His wife was ready for hospice. And so that was really a worthwhile experience for the whole family as far as talking about negative experiences. So it is very possible. Do you have anything to say about costs?
In hospital, you don't have to worry. It's part of the whole care. So where I work in the hospital, it's not something part of the discussion. Your care is just part of your in-house team. So for inpatient, you don't have to worry about that piece.
So I will say, and I think it's important for this congregation to hear, sometimes there are people who are not documented who need hospice or palliative care. And there are certain agencies in this county, and Livingston is one of them, that will provide that care under subsidized care. They won't be able to benefit from the hospice till very end, but they will do subsidized care for palliative care and protect them from whatever entities may be that they really do care. So I think that's also an important thing to know. We talked about this. Most common conditions seen by hospice and palliative care are basically the same, aren't they?
Sure, yeah.
Yeah.
I think we kind of touched on a lot of those during our...
And then the most common symptoms treated are basically the same. So pain, loss of appetite, nausea, vomiting, insomnia. I think we may use some of the same medications.
Most certainly.
Yeah. Shortness of breath. This is where I like to talk about morphine, the magic drug that people thought was only for pain. Morphine was actually first used for shortness of breath. And then they discovered it worked for pain. And so a little bit of morphine can help people relax. It opens up the blood vessels, so more oxygen is circulated and helps with the shortness of breath in limited amounts. And constipation is always a huge issue. Actually, the hospital's better about treating this because you have certain drugs.
Lots of things we have lots of things. And we didn't mention spiritual crisis or existential crisis on that, but that's important because we have our chaplains. Those are super important for serious illness and end of life.
It is. And in hospice, that's part of, actually the whole team does it. So it's an amazing thing. Anything you've thought about that?
No, I think that's...
I guess it's their turn.
Okay, time for your questions.
Palliative care that also require primary care. They have to initiate that just like same as
Hospice, they order palliative care?
yeah.
Yes.
Okay, so palliative is just individual services where hospice, the doctor says they need.
So in the hospital,
In the hospital, the doctor will write an order for palliative care consultation, and that's our whole team. Are you asking about in the community? Yeah, so then that is, it runs like home health. I believe your primary care doctor writes an order, but you still get the whole team. They send it to a certain agency,
they
right?
send it to a certain agency, and then the agency will send a nurse out to do the assessment, and then they will contact the doctor for the specifics. Okay?
So you can definitely ask your primary care doctor, and hopefully they are familiar with the service.
Well, and part of the serious illness conversation that should start with your physician, even before, as you're looking at palliative care before that, is the choices. You know, a doctor will automatically order all these tests because they think that's what they need to do, or all these treatments, and there needs to be a conversation. I've showed the video, and I don't think we've ever shown it here, called Consider the Conversation, and that comes up in the video as this lady is going, why do I have to go it took her an hour to get ready to go to the doctor or to go get her labs, and it really wore her out. And so she was saying, do I have to go every week to do this? So they determined how often, and that's a palliative care conversation. How often do I need to have these labs? Are they really important? What if I have this MRI and I have to lay here for an hour and a half, it creates pain, and I have to take extra drugs? What are we going to do after that? So those are some of the conversations to have. It's your choice. The doctor is there for you.
Okay, if you have questions, please use the mic so that everyone can hear. I'll bring it to you, or Yvonne will bring it to you. Yes.
So,
Okay.
do you want to ask the question? I'll hold on
Yeah,
to this.
that's how I thought we were going to do it. I'm sorry about, I didn't have a card.
Yeah.
Oh, well, is it going through now?
It is.
Yes.
Speak in.
Okay,
Yeah.
there we
There
go.
you go.
Anyway, okay, so I was with an older lady who was terminal, and she was signed up, we signed her up for hospice. And the next day I was supposed to take her to the dentist, and I'm calling her and she's not answering, and so I went over there and she was laying on the floor, and I couldn't tell if she was breathing or not. So I called 911, and they came and turned out, and then the dispatcher was saying, well, is she breathing? I said, I can't tell. So they told me to, push on her chest, and I did, and all of a sudden she, was okay. I mean, she kind of screamed, sat up, well, she didn't even sit up. But then I guess it was the paramedics came, and the fact that she was on hospice, I shouldn't have called 911 is what I'm finding out. Of course, what did I know at the time? It was the first time I'd ever done anything with hospice. So apparently I was just supposed to call a hospice nurse, but I didn't know if they were going to be there in time because I didn't know what was happening, but it all surprised me. And so, again, what did I know? So I think hospice needs to maybe let people know a little bit more about what to do in a situation like that.
Okay, I'm just going to remind people, after they answer your question, they are going to take the questions on the cards.
Okay.
All right?
Okay.
But they'll go on and answer your question, and then they're
Okay.
going to read the questions on the cards.
Okay.
You'll have chances to ask questions too. So, first of all, I want to applaud you that you didn't realize that you weren't supposed to call 911. If you walked into a situation and saw a person and didn't see signs that said, please call hospice, don't call 911, you did the right thing. And I want to applaud you on that, and I want you to erase that doubt from your mind, okay? You did an amazing thing. So I don't know if they had signs that said, don't call 911, call hospice. So they should have been posted, first of all. And were you one of the primary caregivers? Or were you a friend stopping by?
I was doing a lot of help with her. I was not a paid caregiver or anything.
But you were there caring for her. You were a caregiver.
Yes, yes.
Let's honor that.
Yes.
So you should have been educated. This should be part of the ongoing education when a person is on hospice. So you are correct. You should have been educated, and there should have been reminders posted to not call 911.
Okay.
So you didn't do anything wrong.
Okay, but would they have gotten there in time? I didn't know what her situation was.
Right, and
Right,
that's why the
that's the problem.
education and the was important. And I apologize for anything, just generally for hospice, I'm saying that.
Okay.
But also they could, did she at that time have a pulse? It's a bigger question than it looks like, right?
Yep,
I don't think you
couldn't
had
tell.
all the information, and that
You
must have been
should-
really scary and traumatic.
what I
so
think.
don't feel badly, because this happens all the time, even when people know that they're not supposed to call 911.
Oh my
when
gosh.
it's a really scary situation, it's, any reasonable person you're not necessarily going to think and remember. So hopefully, our
Exactly.
talk that we're going to do in September, Terry referenced the pulsed form. It's a pink form that hospice patients should have posted in their home. So if you call 911, the paramedics can see, do not resuscitate. But
Right.
under your situation, anyone would have done that, because
That's
you
what I
don't know-
think.
You didn't. That happens all the time. It's
So-
I'm not.
Okay, well,
It's
yeah,
almost a
and
normal response unless you really are there and really working with the hospice, and
they
they
shoulda-
just told you.
they
you
shoulda
weren't that- you
educated
didn't
and it
live
was the
there, you
next
weren't-
day. It was the next day.
Well,
It's
and
like,
a
yeah.
good hospice will give you a form that says, do not call 911, call hospice. Call hospice. And they give you the phone number. Livingston, big, bright, yellow signs.
Yeah. So
8 by 11. You can't miss it.
yeah. So
So that was the hospices, so no problems with that. No bad feelings, please. Okay.
yeah, that's
It is.
understandable.
Well, and to be fair, I had a patient who, respiratory illness, he was dying, and his stepson came along and he said, why aren't you calling 911? And I said, because he doesn't want me to. I actually turned to the conscious patient and I asked him, in front of his stepson, do you want to go to the emergency room? No. He did not want to. So I had a conversation with the stepson in another room, and again later he asked me the same thing. I said, he does not want to go. So sometimes it's
difficult
It
if
can
you
be
think
difficult.
someone's dying and to just be there, not know what to do.
yeah. And the stepson was frightened. He was just basically frightened. So this is a hospice question. What should you do if a hospice provider turns down the application for your loved one? So it would depend, the application, it would need to have an order from a physician, and if the providing physician thought that there was a terminal illness, then the director and the case manager would be looking at that. They would look and say, is there really a terminal diagnosis here? And if they still turn that down, I would question it. If there was a terminal diagnosis, I would go to a different hospice provider. Is that clear?
Well, yeah, but usually if the physician writes an order, they're pretty confident
Yeah, so
that they meet the criteria.
It should meet the criteria. And one of the things they can't put on that anymore for a terminal diagnosis is failure to thrive. So that cannot be a diagnosis. Failure to thrive is not a diagnosis, so they have to be more specific. The other part of that, doctors don't often understand, and this is very specific, for dementia, there's a FAST level, and so they're counted in levels of 1 through 7. And a person who's ready for hospice who has dementia has to be in the 7 later C area, where they don't communicate clearly. They have to have help ambulating, getting around, and they cannot really feed themselves well, or they've lost a lot of weight. So is that clear? So that may be a reason that they would say they're not appropriate yet.
That actually happened to me with my own mom, who suffered from dementia. In hindsight, I believe it was vascular rather than Alzheimer's. I kept asking her physician for hospice because I knew she could benefit, but she, with the dementia, it just wasn't getting to that point. But then because I think it was vascular, she had some more mini strokes. And then, so that I didn't mean for her to only be on 2 weeks, and I certainly tried to advocate. But sometimes it will, with dementia, and particularly, there's some event and it escalates it rapidly. So that's a kind of a tricky one to get the time.
And with vascular dementia, she could have possibly come on earlier if there were other proofs showing that it was cardiac. Yeah.
Yeah, I think maybe a different doctor in that case.
And also different case managers know how to look for those symptoms. So, yes, ma'am? Yeah, maybe.
Been denied services from the hospice organization that her referral had been made to, and we were given very little information about the denial. She did die within a couple of days, and believe me, she died of Alzheimer's, not with it. But we were fortunate. Somebody overheard us in a public hallway and stepped forward, who was a representative of another hospice organization. And they served us very well for the few days that she remained alive. But I take it, is this common that those of us who may be looking for this type of care for a loved one with dementia, Alzheimer's, that these are going to be more difficult instances with hospice care than perhaps other types of medical conditions?
It's all going to be independent for that person and the support of the family. The other part that they may turn down somebody is you have to have a 24-hour caregiver. You obviously had a 24-hour caregiver. You were able to do that, correct?
She was in a care facility.
Right. So that's sometimes a reason that hospice is denied families, or because they don't have somebody who can stay there 24 hours. The lady I referenced at first needed the heart valve replacement. She didn't need a caregiver at first, but we knew she was going to have one. So we had to plan for that, and she had to. Her daughter wasn't able to do it, so she was going to have to hire. So sometimes that's a complication for coming onto hospice. There's other complications. She was in a facility that was already there. In a nursing home, the difference in a nursing home for Medicaid, and this is what I wanted to cover, Medicare pays for hospice, but in a nursing home, a skilled nursing facility, Medicare does not pay for board and room and board when a person's on hospice. And where does that cost land up? It lands in your lap as a family. And you can't afford that, so then people don't want to go on hospice. So there's a two-edged thing. Interestingly, Medi-Cal pays room and board and hospice, and they can stay in the facility. Our healthcare system is so hard sometimes to figure it out.
But if they do have Medicare and Medi-Cal, which most people don't from Camry,
Yeah.
then you could get hospice at skilled nursing. Otherwise, that's one of the main things as a social worker. I work with a family,
This is why we
determining the setting.
This
because
is
that
why we
becomes a
need you.
sticking point.
Yep. So did that answer your question, Susan? No?
Again, I accept the fact that every situation is.
It's different, and every hospice is different, and that's why I always breaks my heart when somebody has a bad experience with a hospice, when hopefully they can have a positive. My heart's saying, oh, I hope that wasn't Livingston who did that. So I don't think it was, but you never know way back when. The changes, happen. So how do you select among various hospice providers? I didn't even know this was in my hand.
Oh, boy, I organized it.
So you actually can do interviews. You can have if you're not in a hurry, and you can do interviews of the different hospice agencies and ask them what the difference is. The other thing that's important to know this about choosing between hospice providers, and this is also true for home health, is to remember that even though a social worker in a hospital or a discharge planner says, this is the agency we're referring you to, if you get them and you don't happen to like them, you always have the right to change, and it is not held against you. So you could go with hospice ABC, they come and you go, I'm really not happy with this, it's taking forever to get anything, I'm not getting a response, I don't happen to like this. Any of these people, you can say, I want a different hospice agency. The same is true for home health, and you have the right to know that.
We have another
Okay.
question. Go ahead to our. Thank you.
Oh yeah, that's yours.
If hospice is denied, is palliative care an alternative? It should be, again, depending upon health insurance and coverage, because, not every, Terry mentioned that Medicare covers it, some Kaiser back and forth, but you should certainly ask. And the other workaround is home health is always covered if you meet the criteria, the homebound. And so sometimes what we have to do to get creative is refer somebody to a home health that also has a hospice, and so then they can refer them. The nurses will work with the patient and family on transitioning them to hospice when the time is right. Because it does happen for this or that reason where we can't get people on hospice even if they wanted it, and sometimes we think people should be on hospice, but the patient and family is just not ready to accept that. If they at least start with a strong home health company that also does hospice, then they get to know the nurse, and I think they may just need some support to make that option. So yeah, it's a good idea. At least get on something where they have some knowledge of palliative care and hospice.
So why do you think doctors are so reluctant to refer to hospice or palliative care? Or why is it so underutilized, unknown? So doctors, especially oncologists and some urologists, they don't want to be a failure, and they feel like they've failed the patients when they do that. So, which is really unfortunate. In fact, I know that people have said to Dr. Dial that you're killing my patient.
Oh, I had that happen. When I worked at Simi Valley Hospital, I got in a big fight with one of the pulmonologists because I referred his patients. And I hope this is not most doctors, but he didn't want to lose his patient because of the finances. Now, some hospices let the physicians work alongside, but some doctors do see that as a threat. And some of them are actually just attached to the patient, and then it becomes personal issues. That with some of these very sweet primary care doctors that have been in the community for years and had their patient for 40 years, it's hard for them to sometimes accept.
And sometimes they also recognize. So actually it's law that they have that choice to keep their primary care physician. So when you interview somebody for hospice and you say, so this is how this works, and I will tell you specifically in this town, Dr. Allen would like to keep his patients. When the patient goes on hospice, he is their physician, and then if he's not available, if a nurse needs to talk to him about medications or changes, then we have the backup of the medical director. The medical director and the physician have to agree on medications, and they have to agree on the terminal diagnosis. So does that make sense? So again, doctors they're reluctant because they think they've been failures. They often, believe it or not, don't recognize that it's time, and they are not as educated as we'd like to think about palliative care.
And they don't know how to have the conversation. It's a difficult, time-consuming conversation, goals of care, and a lot of doctors don't have. You only have a few minutes with them. We spend an hour with families.
Exactly.
You can't rush through that conversation.
You can't. And so I didn't tell you, I'm the chair of the Coalition for Compassionate Care in Ventura County, where our goal is to educate the healthcare community and the public on advanced directives, post, end-of-life, serious conversations. So we're still working at it, and there are doctors who don't understand hospice is for longer. It's not just for a couple of days. We don't just kill people, and they don't understand palliative care. So
I think there's a lot of misinformation and emotional barriers for people and physicians and healthcare providers, all of them. Even doctors and nurses that work in the hospital sometimes are reluctant.
this is true, very true.
Unfortunately.
What's the time limit for home health and palliative care? So time limit is based on patient need. So if a patient has wounds, say they've had say have surgery and they have deep wounds, and they need help with those wounds. Now remember, home health basically is the idea you teach the caregiver how to do these things. But a deep wound would allow a nurse to come in and not only teach that caregiver, but to come back and monitor how it's going, so that, or have IV fluids, or have physical therapy that they're progressing. So as long as there is a need, a skilled need, then home health can stay in palliative care. So, and they tend to focus on the nursing part, not the physical therapy or occupational part. Unfortunately, I actually double-checked it. It's true. I have to tell you, and this is hope, that in the state of California, they're working on passing laws with the finances behind them to cover palliative care. It's just
Good.
a very
It's needed.
slow
Right.
process. Does Medicare pay 100% for the hospice? Yes.
That's my question.
Yes.
But is that just Medicare or with a supplement?
No, that's just Medicare. It's like reverting to the yeah.
Yeah, and if you have a supplement, even if there were any copays, or it might help pick up things that weren't covered. So, I mean, hospice really, basically, unless you're a young person, sometimes we get in trouble where they don't have hospice coverage. But anybody who has
Very seldom.
Medicare, the finances of the actual care is really not an issue. It's the hands-on, the medical care is not an issue. You don't have to worry about cost. But the hands-on care and placement, that won't be covered by Medicare.
The 24-hour care. And the other thing that I should make clear on this is the medication. I said medication that is for treatment of, for terminal diagnosis. So there are people who want to, say they come on for let me think about this, diagnosis. They come on with vascular dementia. And so certain things are not going to be covered by Medicare, that medications they may want to continue. So that may be provided by the insurance company, if you can negotiate that, or out of pocket. But things for sleep, things for nausea, things for pain, all of that is covered by Medicare. And we use just like your doctor does or your hospital does, there is a formulary that they have to match, they have to follow. That's just part of life. The Advantage plans, it reverts, if they have to stay on the Advantage plan because you were a federal or a railroad employee, then that's covered. but that Advantage plan, if you're not a federal employee, reverts back to Medicare, and that's 100%. Yeah, that's like my Kaiser plan. I'm 68, so I know this. I knew it as a hospice nurse. I read it from the cards. I read it from the card. She was asking about the Medicare Advantage plan, and that's what I was clarifying. Okay.
I was going to wait till you finish your cards.
Oh, okay.
well.
Is it part of the last question?
Well, it's actually part of what LaJean said when she was relaying that situation about knowing and calling 911. My question is, are hospice patients aware, like, if you don't call 911, maybe help doesn't get there in time and they might pass away? I mean, that sounds cold, but is that something that's apt to happen, or they just understand that that can happen?
So yes, they understand that that can happen.
That's kind of the goal. I mean, I'm not going to say the goal, but I mean, our goal for people being on hospice at home is to die at home with comfort. So, I mean, usually, and we spend a lot of time going over this in the hospital with our palliative care team, is that somebody really has to be ready to not go to the hospital, and they're, normally people that go on hospice are just so worn out. For whatever reason, they don't want to come to the hospital. Most people hate being in the hospital. So usually by the time we get people, we suggest hospice care, they say, I want to die at home. I just had this lady, I just want to be with my dog, and so they don't want to come to the hospital. So usually part of that discussion is that we're going to care for you at home through the end of your life. So that is something that is explicitly stated, and that they would agree that they don't want the paramedics to come and drag them off to the hospital.
So, but it is, she's talking about somebody may die without the nurse being there, and that does happen.
We don't.
She didn't have to wait to call hospice. She could have called hospice if she had known. So. So if a person's on hospice and we call the hospice agency, they would ask you and they would say, we can send a nurse right now. If that person's on hospice, as Jennifer's saying, the intent is that they're going to die at home. And then the 911 would be kind of a moot point. So.
I know, that's why we're saying don't feel bad for when you call. But you have to, it's scary. I went through this with my own mom. She was out of board and care. She passed last June, and I had her on hospice. And the board and care caregivers were very uncomfortable. The day she passed, I had to go out there and call the hospice myself and sit there until they got there. And then they took over, and they did a good job. But clearly her caregivers were super uncomfortable with it. So that's why you need a really strong hospice that's going to get that nurse, that chaplain, social worker out there to be with the family. And some of them do. Terry mentioned continuous care. Some, I don't know if LVNA does, but certain hospices will. In that case, and this was a small one, even they did continuous care with my mom. They stationed one of their nurses there for the duration because they know this is frightening. You don't know. I mean,
and they have to be able to be there 8 hours, document 8 hours in order to get continuous care. It's got its rules.
Right, but the goal is to give you support so that you're not, and my palliative care nurses that I work with are amazing, and so they do a lot of education, and we have a booklet that we hand out so that education for the family on what signs of impending death look like. I mean, it's really, people need support, and that's what hospice is designed to do that. It's a frightening emotional time, and without that support, how would you just be? It wouldn't work.
And you may not know. And on the other hand, there are people that the nurse has worked with them, the social worker and the chaplain long enough that we know it's coming, and then they say, do you need somebody to come? And they say, no, we're fine. They don't actually want anybody to come and pronounce. So that also happens. And actually that happened with my brother-in-law 22 years ago. I happened to be the nurse in the home at the time in Northern California, and I called and I said, Randy has died. And they said, do you need somebody? And I said, no, we're fine. They just sent somebody to pick up the body. So,
And I should say, some people just don't want to die at home, and that's, again, where social work piece to try to come up with, should they go to boarding care, assisted living, what are the other options?
yeah, they're frightened of, yeah, there's a lot behind that. So,
Can you self-refer to palliative care, or must a doctor refer you? So I think we kind of covered that, is that there has to be a doctor's order. But you can bring it up, and probably should, now that you know about palliative care. If you think you or someone else could benefit, you can ask your doctor, and if they may need some clarification, maybe you even know an agency to use. But you can and maybe will be the person to bring it up with the limited knowledge there is, but it does require a doctor's order.
yes. I have referred people to the outpatient palliative care and say, you need to talk to your doctor about this, but call them, because I know the outpatient palliative care community will help them get that going.
Right, we might call the doctor's office and try to help get the
Yeah.
order.
So,
Jennifer, does most CMH doctors, are they aware of palliative care?
In the
Most-
hospital?
What, no, I'm talking
Outside?
about outside.
I
Are
don't-
most of them
I wouldn't,
internists?
I wouldn't bet on all of them because, all the intensivists in the ICU know all of us, but they may not be aware of that option. But that's our job, because we have two amazing physicians that will call the attending physician and make suggestions.
Okay,
So they lean on our doctors to give them advice. So that's if you're in CMH or Simi Valley or Los Robles, where they have a great palliative care team as well.
Okay,
we can
so
help
if
with that.
I say to my CMH internist for my mom,
Okay.
who's 92 years old, who just got out of hospice because she didn't meet the criteria any longer. She was one of those where the facility
We'll
started
see- we'll
taking
see you
very
again
good
later.
care of her, and she didn't meet the criteria. So if I say to the CMH doctor, let's, which I already did with him about home health,
Oh,
And
okay.
he's a new
New
doctor.
doctor. Yeah, that happens.
if I say, let's look at palliative care, what's he going to do? He's going to go to,
Well, I have a flyer out there for our outpatient palliative care you can pick up, since you're within the system. And then the question is, do you want
Okay.
palliative care through home health, or are
Yes.
you willing and able to bring her to our outpatient clinic?
no,
Okay, if
Home
was her
health.
hospice agency, do they also have home health? It could be easier.
no, they did
No?
not. No, her hospice did not. Once I brought her to Camarillo, the company did not have home health. It was just hospice.
so, and this I want to say about a hospice and home health, and I'm going to be really adamant about this. There are a lot of agencies who are in the valley, in other parts of LA, who send in and they say they have home health and hospice in Ventura County. But a lot of those practitioners, clinicians, are working from out of Ventura area, and it can take them a long time to drive in here. So do yourselves a favor when you have a home health and hospice, make sure they're actually in Ventura County and that they can service you on a quicker basis and actually a more heartfelt, not financial basis. I'm sorry it sounds really blunt, but I know this for a fact.
You can contact me offline, and I can help give you a little more direction on who can
how
take
to
care
do
of
that.
her.
Thank you, Jen.
Because she
Yeah.
still may be hospice appropriate. She stopped declining? Dementia. Yeah. Oh, she met a CHF, though?
Yeah, well, maybe, yeah, again, offline, I can I'm not going to recommend a certain place, but I know which ones cover hospice and home health
Yeah.
palliative care that have a lot of local nurses, and that could take good care of her. So
And
I'm
I will-
happy to throw
yeah.
that, but not in front of everyone.
Not in
but-
front of everybody else, and
Yeah.
that's why I'm trying to be careful about,
Yeah.
because I'm not here for an agency.
No,
I'm
we
here
can-
for facts. So,
I'm not with an agency, so it's easier
well, you're with
for
the
me.
hospital.
Yeah, but we
so-
don't have our own
Yeah,
home health.
so what I will say also is that as we have younger physicians, practitioners coming up, they're going to be more knowledgeable about palliative care and hospice because they are having more time with it in their residencies. So we do have a positive picture coming up. It is true. So, and thank you for this question, this last one I have. How are families made aware of post-death hospice bereavement care, and what are these services? And I meant to mention it during the slides, and I totally forgot, so thank you for the question. Bereavement care is part of the hospice benefit required by Medicare. So that's part of the reason for social work and chaplaincy is to follow up a year and a day after the death. And they should be calling you, they should be checking, they should be asking questions, they should do an assessment, and if you're fine and you don't want to be bothered, they're going to be okay with that. But they're also going to say if you need more services. Sometimes people need a deeper service than just a phone call. They need to be in therapy, and they can suggest that. And that does happen. And so that is part of what the Camarillo Hospice does, and they do it before death, and they do it after death, and support, they will suggest a support group, and support groups are very, very important. So did that answer that question well? So, and let's say this. Let's say that you have somebody die. Jennifer had your mom die, and you seem okay, and you don't think you need anything, and 9 months down the line, you're going, oh my gosh, what's wrong? You have the right to call them and say, to call back and say, I need help now. So, and they will make one-to-one visits too, besides phone calls. Well, that didn't happen well during COVID, but that's happening again.
Yeah, we went through a weird couple of years.
So, yeah. Any other questions?